Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenter is Dr. Harpreet Dhillon. Dr. Dhillon is an internal medicine physician with the Washington Township Medical Foundation.
Hi guys, I'm Harpreet Dhillon. I'm an internist here in Fremont. Been practicing here for about the past 18 years. Did my training, medical school and residency in the Midwest, Chicago, Detroit. I did a year of surgical residency in Detroit when I thought I wanted to be a surgeon, and realized that my heart was really in medicine and taking care of, patients who had chronic illnesses and be able to provide them longitudinal care. So I came back to medicine, did my residency at Fairview General Hospital, which is part of the Cleveland Clinic Health System in Cleveland, Ohio, and then I started practice here in Fremont. So the topic today is prevention and wellness. And why bother? Why do we want to live in a manner where we have to prevent our health and ward off disease? Well, the reason is because in order to live a long and healthy life that is meaningful, we have to practice prevention. Because we know that when we practice prevention, we give ourselves the best chance of not acquiring any kinds of chronic disease process, like diabetes, heart disease, high blood pressure, and diseases that are related to that, like heart attacks and strokes. So we know prevention matters, and that's why we bother with it. In fact, probably about 80% of our time when we're treating patients is spent on prevention, because we know that by preventing the disease, we can actually make a difference. By preventing the disease, we can ensure that you're going to live longer, healthier lives, because once the disease process occurs, then our options become largely limited. And then we're just trying to prevent the complications of the disease process. And that's why prevention is more important in this instance than curative medicine. Because by the time we get to curative medicine, the horse is out of the barn, let's say. It's gone. There's no way to sort of reap the benefits. So, as I mentioned, we have sort of time continuum here where you start off with no disease and you're asymptomatic, and then you have disease onset. You become either symptomatic or asymptomatic still, and that would be the case of, for example, somebody who had early diabetes or early high blood pressure. They don't have the disease itself, but they're on that border where their blood sugars are sort of in that impaired glucose range, where we start thinking about them developing diabetes. If we don't intervene, they will get diabetes. So that's where prevention really comes key into play. And then you develop the clinical diagnosis, for example, in this case, diabetes, and then, unfortunately, the clinical course progresses after the development of the disease, and you get complications of the disease, and it's a situation where things unfold, but they unfold for the worse. So there's levels of prevention. So when we talk about primary prevention, we're talking about strategies that are intended to avoid the development of the disease process itself. So most population-based health promotion activities that you see are primary prevention measures. So for example, if you go to a health fair and you check your blood sugar, you check your cholesterol if it's available, those are all preventive measures to let us know whether you're at risk for developing either high blood pressure, diabetes, or high cholesterol. So a lot of times you can have there'll be fairs. Washington Hospital conducts a lot of them where people can get screened, okay? And that's where the primary prevention strategy falls in. Secondary prevention, well, this occurs when you go to the doctor's office and the doctor is attempting to diagnose and treat an existing disease in its early stage before it results in significant morbidity. Meaning, let's say you start developing diabetes, then your doctor can say, okay, we know that you have diabetes, now let's make sure that it doesn't progress. So he will then use strategies to decrease the rate of progression of the disease itself. And that's what happens in the doctor's office. They order a bunch of labs and tests to make sure that A, not only are you accurately diagnosed, but B, that whatever we're doing is going to help retard the progression of the disease process. And then finally, there's the tertiary prevention. This occurs when you have the disease, and now the key goal there is to restore function and reduce disease-related complications. Hence, in the example of diabetes, we know diabetes is related to other chronic conditions like heart disease, kidney failure, poor circulation, and our job as physicians, as caregivers, is to make sure that we don't let that process go forward, that we can prevent those comorbidities and the chronic conditions that occur from diabetes. Coronary prevention, this is a prevention that, so I call it the blind leading the blind, where somebody thinks they have a disease process or an illness, and everybody starts ordering a bunch of tests regarding that illness or that symptom or that disease, and they don't actually have it, but people are ordering tests, and then other people are following tests by ordering more tests. So that becomes coronary prevention, and we don't usually practice that, as we'll show you in the next slide. So that was very confusing, right? But let me make it a little bit more simpler for you. This is a simple 2x2 table where on this side we have the patient side, and on the other side, the top side, we have the doctor's side. So the prevention levels in the patient side is whether they have illness or not, whether it's absent or it's present. Absent is in yellow, present is in red. And on the doctor's side, whether they have the disease or not. So we're looking at it differently from different points of view. From the patient side, it's an illness, but from our side, is it a disease? That's what we're trying to figure out. And is the disease absent or is it present? Okay, so if illness is absent and disease is absent, then that's primary prevention, okay? That means that you don't have any symptoms and you don't have the disease process. And we're utilizing techniques or measures to reduce risk factors. For example, if it were diabetes, if you were at risk for diabetes, we'd be telling you to lose weight, exercise, watch what you eat, make sure you don't have high carbohydrate diets. Okay, so as far as secondary prevention, we know that the illness is absent. Patient is asymptomatic. They don't have any idea. They either have high blood pressure, diabetes, or cholesterol. But we know the disease is present because we've done tests, and it shows that you have borderline cholesterol, you have borderline diabetes, you have borderline high blood pressure. In fact, on average, you have these disease processes 5 to 10 years before the doctor can even diagnose you, because that's the lead time it takes to get to secondary prevention. Okay, so people already have this going on in their systems for 5 to 10 years before they're actually aware of it. And then the tertiary prevention, we know illness is present, patients feel horrible, and we know disease is present because we've diagnosed it and we've documented it, okay? So this is a patient now who has diabetes mellitus type 2, who may be in their 40s or 50s. And our goal then is to prevent the progression of the disease and the complication of the disease. And as I mentioned, coronary prevention, illness is present, but disease is absent, but we don't really know what the illness is from. So when we start ordering a bunch of tests, trying to pinpoint that illness, the process just kind of unfolds and people order tests after more tests. That usually leads them to the wrong diagnosis. But clinically, coronary prevention is usually not a problem. We know that by modifying risk factors or eliminating or reducing risk factors, we can prevent disease. We have evidence to support that. And what are these risk factors? Well, if you look at the top, hypertension is the most preventable disease factor that results in death worldwide. This is data from year 2001, followed by smoking, high cholesterol, malnutrition, in certain populations, either alcoholics or other types of processes where patients don't get adequate nutrition to their bodies. Sexually transmitted diseases, we'll touch on this later. Infections can play a big part in developing disease, chronic illnesses like hepatitis, AIDS, and so we can prevent that by screening for these sort of things. As well as, poor diet in westernized countries, for example, fast food diet is not a good diet, can lead to overweight and obesity, which can lead to physical inactivity, and then the process just kind of snowballs from there. We know alcoholics are at prone for developing multiple types of cancers, which we'll touch on, as well as liver disease and dementia. Alcohol chronically can affect the brain and cause alcoholic dementia, as well as patients or people who live or work in areas where there's air pollution. We know that leads to chronic types of lung illnesses, not necessarily from smoking, but you get chronic scarring and fibrosis of the lungs from poor air. And obviously in third world countries, unsafe water and poor sanitation leads to cholera, dysentery, and many types of deaths related to dehydration and infections. Preventive health, of course, we can touch on behavior and emotion for depression and suicide. We can look at sexual behavior. We can find out if people have STDs. We can screen for them. Whether it's HIV, we can screen for cancers. We can screen for diabetes mellitus, and of course we can screen for vision and hearing problems during your annual physical. So we can identify 4 identifiable prevention strategies that I will talk about, which are vaccinations, behaviors, injury prevention, chemoprophylaxis, and I'll tell you what that is, and cancer screening. Okay? These are the 4 large, broad categories of prevention. Okay, so let's talk about immunizations first. There are 3 types of immunizations that we believe are very important in preventing disease: influenza, pneumococcal vaccine, and tetanus. And this is largely in the adult population we're talking about. Of course, in the pediatric population, there's other types of immunizations that are beneficial, but we're largely speaking about adult population here. Okay, influenza. We know it's an epidemic or it's an endemic infectious with outbreaks which occur annually in the US. Virus strains change annually because of antigenic drifts and shifts. These are the properties of viruses that as they infect the host, they have the ability to change their envelope and change their protein structures so that our vaccines become ineffective. So this is a process, vaccine and viruses, that's always ongoing. And every year we have to look at the antigenic drift and shifts in the population to determine what type of a vaccine we're going to use every year based on this data. The CDC conducts surveillance and develops a vaccine. That's the Center for Disease Control, which is based out of Atlanta, Georgia. 20,000 deaths usually occur during epidemics, and usually this is most among the elderly who are not vaccinated by the influenza vaccine. Again, so the elderly are at greater risk. We know patients who smoke end up developing COPD, which is chronic obstructive pulmonary disease exacerbations, if they don't get the influenza vaccine. People who are diabetic are immunocompromised, so they also need the vaccine. Patients who have chronic renal failure, again, these are patients who are immunocompromised. They need the vaccine for protection, as well as patients who live in long-term care facilities who live amongst other elderly people who are sick. And we know that influenza causes respiratory and systemic symptoms that are very debilitating. Again, I mentioned the 20,000 deaths beforehand. So we make sure that everybody in the hospital, when they're admitted, get influenza vaccination, as well as when they get admitted to nursing homes. And the common complication of influenza, because we know affects the respiratory system, is pneumonia, which is the actual causative factor that causes people to die. So the vaccine is usually administered in October or November. The antibodies take about 2 to 3 weeks to form in your body. The titers decline over 2 to 3 months. That's why it's probably good till maybe January, February, right when the flu season hits its peak. And then, of course, the flu season starts in December, January, February. So you're well protected if you go ahead and get the vaccine in September and October. If you wait too long, if you wait till January, then sort of you're behind the 8 ball on that, because there's already antigenic drift. The vaccine is already preparing to change its morphology by that time. So the virus is already planning to change its morphology by that time. Antigenic drift is occurring. So the original vaccine that you got in October is now changed, so it may not work if you get it in, if you get the new one in January, February. So the best time to get it is September, October, so you build immunity to the influenza virus. Contraindications are allergy, people who are allergic to egg protein. Side effects of the vaccination might involve minor muscle aches or redness at the site of injection. Okay, and the vaccine contains no live virus, so it's not contraindicated, meaning you can give it to pregnant women because it's an inactivated virus, not live. It's not live. The second one that's very common that we like to make sure that the elderly and adult patients receive is the pneumococcal vaccine. It's 4 times more common, more likely to cause death in the elderly, as I mentioned before. The pneumococcus, or the strep pneumo, is the #1 cause of pneumonia in this country. It's less likely to have classic signs and symptoms of pneumonia. So again, elderly patients, they may not come in with the usual high fever, high white count, can't breathe, typical findings on chest x-ray, as somebody who's younger might come in. They just might come in and not feel well or have abdominal pain or be confused or, just something is off. And oftentimes it can be pneumonia, even though they don't have any respiratory symptoms. And again, the 23-valent vaccine covers most strains in the US, and that's the one that we recommend. So it provides protection for up to 8 years, okay, after the age of 60. It only needs to be given once or twice. And in immunocompromised people who have renal failure, chronic kidney disease, sometimes even diabetics, the frequency is more common. You need to give it about every 5 to 6 years because the immunity does wane. Again, there's minimal side effects of the pneumonia vaccine. And finally, the third one is tetanus. Most people don't think of this, but tetanus is uncommon in the US because most people are already vaccinated, either through their job or through schooling. Every 10 years, people usually get a tetanus booster. Incidence and mortality are higher in the elderly who are not vaccinated, and there's a primary series of tetanus immunizations. So behaviors is another tenet as far as primary prevention. And we know that cigarette smoking, alcohol use, physical activity, and diet are all related to people's behaviors that can cause illness and disease processes. So cigarette smoking is a major risk factor for morbidity and mortality in the elderly. The risk factors are, of course, as we know, cardiovascular disease, cerebrovascular disease, which is stroke, cancers of the lung, esophagus, oropharynx, head and mouth, stomach, pancreas, bladder, and there's multiple other ones that we can also put up there. We know that it causes chronic obstructive pulmonary disease, which is end-stage lung disease. We know it causes poor circulation, which is peripheral vascular disease. Arteries just get tighter, and there's not enough circulation in the extremities, so oftentimes people get cold, sort of red hands and feet, and get real cold. And we know it causes kidney disease. So of course, cigarette smoking is directly related to the amount and the type of tobacco that's smoked, usually, in the elderly. Even if you've smoked for 30 plus years and you have 30-pack year history of smoking, it's still beneficial to stop, because what happens is eventually your lung function will resume its natural rate of decay. That is, it'll go back to being to the same as another person who didn't smoke. So it would decline at that rate. Whereas if you smoke, it's going to decline precipitously as far as the function of the lung. Often, it becomes a habit. Older people are not willing to stop. There's often sentinel events related to smoking, becomes a social situation. People sometimes want to smoke and drink, or they go to parties with other people smoking, and so it becomes sort of a habitual social habit. Recidivism is common. There are many attempts that are required usually to stop smoking if it becomes a habit. And of course, we should always advise people, even if they're elderly, to stop smoking. Strategies, again, oftentimes there's motivation that's required both on the patient as well as treatment on the physician. So we need a cessation date that we can all adhere to. So oftentimes patients will pick an anniversary or a birth date or some memorable event in their lives where they will say, in the future, I am going to quit smoking by this date because I'm making a promise to myself. I'm motivated to do it. So we try to keep in contact with the patient. We involve family and friends for support. We can also employ nicotine patches and gums, which can be useful. In addition to biofeedback training and self-motivation, we don't recommend cold turkey because we know that the failure rates are high with that. And oftentimes, if the gums or patches and the other non-pharmaceutical treatments don't work, then we can often use medication to help you stop smoking, which is called bupropion. Now there's Chantix, but there's many side effects with Chantix, including suicide and depression. So we try to stay away from Chantix if we can. So we will often use bupropion or Wellbutrin. And the trade name, I think, is Zyban. You may have heard Zyban. Alcohol is another behavior problem, and it can be used as a preventive measure. Prevalence is not as well known as smoking. It may be more common in patients who are either lonely, have boredom, or have had a loss. Alcohol excess, we know, leads to impairity and falls, can lead to motor vehicle accidents if people are impaired. We know that the changes in mental status, it can cause dementia and behavior problems. It can cause ulcers, known as peptic ulcer disease in the stomach. And of course, malnutrition, people don't get enough vitamins. And again, that can often lead to numbness and weakness of the extremities and the legs. We know physical activity is important, and this is a very simple preventive measure we can employ in our patients. We know that if they're not active, it can lead to greater risks for all-cause mortality, meaning if they have hip fractures and things like that, they have 40% chance more likely to end up in a nursing home, even just with one hip fracture. We know that if patients aren't exercising regularly, they can develop cardiovascular disease, obesity, insulin resistance and diabetes, osteoporosis, which is a thinning of bones, which can occur after menopause and in men aged 70 or older, and again, hip fractures and functional decline. There's many benefits to regular physical activity. Even if you're in the elderly, you can still benefit from it. We recommend that you exercise 3 times per week for 30 to 40 minutes. Warming up, which is not time included in that 30 to 40 minutes, which is warm-up time, which is 5 to 10 minutes. That you perform aerobic or resistance exercises, meaning weight training. Weight training has a huge benefit, even in the elderly, can prevent osteoporosis and falls and hip fractures. That you also allow for a cool-down time period so that you don't incur injury after exercise. And the goal actually is to exercise in your aerobic zone, which is 70% of your maximal heart rate minus your age. So the way to calculate that is take 220 minus your age and multiply that times 0.7. And whatever that number is, whenever you're exercising, either if you're using a Fitbit or if you're walking and somebody's tracking your heart rate, or if you're on a treadmill or an exercise bike, you want to get to 70% of your maximal heart rate in order to get into your aerobic zone to get the effects of aerobic exercise. Again, there's few contraindications to physical activity, obviously disability being one, and cardiovascular disease being another that causes symptoms during normal activity. Again, if you're having chest pain or shortness of breath and you're trying to run an exercise, it's a sign that something is wrong with the heart, and maybe you need to get the heart checked out first and go see a doctor. And of course, unfortunately, orthopedic problems such as strains, sprains, and muscle aches do occur with physical activity. That's why we recommend that you do a warm-up and a cool-down exercise when you do physical activity. Diet. Well, of course, we know that we can retard certain diseases and prevent certain diseases by eating a healthy diet. I mean, you heard the expression, you are what you eat. When you eat a healthy diet, you feel better. However, if you don't eat healthy, maybe you're eating fast foods or you're eating oily food, you feel heavier, and it's just a symptom of how you're feeling. So again, we recommend eating a healthy diet, and I'll get to that. But many older Americans are overweight, 80% prevalence of protein calorie malnutrition. Obesity is a major risk factor, which of course leads to cardiovascular disease, cerebrovascular disease, and diabetes. And malnutrition, if you're not getting the proper diet, can also lead to infection, osteoporosis, and even death. So the elderly are less likely to follow strict dietary guidelines. They maintain their body weight within 10% of their age-adjusted normal weight is what's recommended. If you want to know what your weight should be, basically what you need to do is just add 5 pounds to every inch over 5 feet, and that becomes your ideal body weight. So let's say somebody was 5 feet 8 inches tall, then for every 5 pounds, so every inch after 5 feet, you would add 5 pounds. So that way, that patient would become 140 pounds at 5'8", and that's their ideal body weight. And the goal, of course, is to maintain your body weight within 10% of your age-adjusted normal weight, which is your ideal body weight. Reduce fat intake, eat lean and fish meat. Reduce fat intake and eat lean and white meat and fish. So stay away from red meat, stay away from processed foods. Anything that's packaged that has preservatives are not good for you, obviously, and you want to eat and cook healthy food. So again, eat fresh fruits and vegetables. I always tell my patients, the more colorful the plate, the healthier you're eating. Intake of calcium, fiber, and vitamin D, of course, is important. And if you're not getting it from your diet, or if you have restrictions due to certain religious populations, or if you're lactose intolerant, then you need to supplement with calcium and vitamin D. Ensure you're getting adequate fiber so that you're not constipated, and which can lead to other types of colon problems, including diverticulosis and colon infections. Be careful with restricted diets. Try to avoid them if at all possible. And stay away from foods that are high in cholesterol, which can lead to high mortality due to strokes and heart attacks. The third tenet of behavior is injury prevention, which is important. And we'll touch on this. Falls, automobile crashes, fire, scalds, and burns, and firearm incidents can all be prevented. 1 in 3 community-dwelling elderly fall. 5% result in a fracture or soft tissue injury. Serious falls can result in hip fractures. Most falls occur at home. There's multifactorial reasons why falls occur, and it's important to identify risk factors and intervene to modify those risk factors that occur in falls. So the elderly are involved in more MVAs than any other age group except teenage drivers, as far as automobile crashes go, despite the fact that on average they drive fewer miles. And most crashes either occur in twilight hours and when they're exercising potentially dangerous maneuvers that they're unaccustomed to. Of course, the factors that result in elderly automobile crashes are age and disease processes, which are related to reductions in vision, slower reaction times, impaired visuospatial perception, the twilight hours again, the long shadows and what have you. The use of alcohol, especially if they're drinking, then they're increasing or even tripling their risk of MVA. Not wearing safety belts, oftentimes they'll forget. And comorbid diseases interfering with function, including Alzheimer's, weakness, or sensory loss from chronic illness. So the older people are not likely to acknowledge driving problems. Family members may bring up issues. They're unwilling to relinquish driver's license. So as physicians and caregivers, we always ask about driving, especially over the age of 70. We counsel about wearing seat belts, and we report trouble drivers to the DMV, even if it makes us unpopular. Okay, so what do we mean by chemoprophylaxis? Okay, so chemoprophylaxis is basically just referring to any kind of a medication or supplement or therapeutic that we can employ in preventing disease. A classic one is aspirin. We know that the aspirin data supports its use for prophylaxis. We are not sure as far as its prophylaxis for heart or strokes in certain age populations. However, we are pretty sure that it's a USPSTF grade recommendation. I want to make sure I get that right. B, right? So in people who are ages 50 to 59 who have a 10-year risk of having a cardiovascular event such as a stroke or heart attack within 10 years, if their risk is over 10%, we give them a grade B recommendation for aspirin, okay? And usually these people have to have low risk of bleeding, so they shouldn't have any other issues like anemia or peptic ulcer disease or other things that can be exacerbated by aspirin use. And also they need to be willing to take it for at least 10 years to get the benefit. And again, in women, the evidence is inconclusive. Under the age of 50, aspirin is given either from 81 milligrams up to 325 milligrams. The additional benefits of aspirin in that age population may reduce the incidence of colorectal polyps and colorectal CA, but that's probably a grade B or C recommendation from the USPSTF because there's not enough evidence to support that. But some people will take aspirin to decrease their risk. Okay, the fourth tenet of prevention is screening for malignancy or cancer. Okay, so breast cancer, of course, is something that we all screen for. We usually start at age 50. The incidence increases each decade. And the risks of developing breast cancer are in those patients who have a family history of breast cancer and first-degree relatives. They either had an early menarche or late menopause. They were nulliparous, meaning they never got pregnant, or there was breast disease, they got a benign adenoma or a previous history of breast cancer. These patients are likely, they have a higher risk of developing breast cancer. So the screening in asymptomatic women markedly reduces mortality rate. This is a grade B recommendation from the USPSTF, suggesting that there's enough evidence to support its certainty. However, there are certain populations of patients and families who have first-degree relatives, history of breast, ovarian, tubal, or peritoneal cancers. They are at higher risk for developing breast cancer. So these patients should be offered genetic testing for the BRCA mutation. And oftentimes your physician will refer you to a genetic counselor to get tested for that if you have first-degree relatives that have these types of cancers. Medicare provides coverage for biannual mammograms. Annual clinical breast examinations and annual or biannual mammograms are recommended. We discontinue screening after 75 years old unless their life expectancy is more than 7 years. Then we'll continue on to 82. Colon cancer can be another cancer that we can screen for very effectively. And take this one to the bank, folks. This is a grade A USPSTF recommendation. There is no question about this one, okay? There's every benefit to getting screening. So this one is ironclad. So after the age of 50, the incidence of colon cancer increases each decade. Again, people who are at higher risk have family history of colon cancer. So this is where family history comes into play, both with breast cancer and colon cancer, okay? And people have history of adenomatous polyps or familial polyposis coli syndrome that are higher risk for developing colorectal cancer. So we'll start screening these patients at age 40 or earlier, 10 years prior to what's considered normal. People who have ulcerative colitis or inflammatory bowel disease are at higher risk for developing colon CA, so we'll screen these people as well. And of course, we know this, early detection will increase your survival rate because this is a USPSTF A recommendation. There's only 4 USPSTF A recommendations, and this is out of like 99,000 things that the USPSTF monitors. They've only given 4 A's. So this is one of them. So this one, you can't argue against it. Obviously, colonoscopy is one of the techniques or one of the tests that we screen for colon cancer. But the fecal occult blood test in randomized trials has not been a very good screening tool because of the high false positive rate. So for example, people, if they take certain medication, like aspirin or amiodarone, or they eat certain types of foods, can get a false positive fecal occult blood test, okay? Doesn't mean they have blood in the stool, but just means it's a false positive test. And then, unfortunately, they would end up getting colonoscopy. So that's why it's not, by itself, the fecal occult blood test is not a great screening tool, and we don't recommend it. However, in those patients that cannot tolerate colonoscopy or the prep for colonoscopy, we recommend that they do a fecal occult blood test and a flexible SIG, which is a mini colonoscopy, every 5 years. And of course, if your fecal occult blood test is positive, then you are going to get the colonoscopy regardless. So it's better to do the colonoscopy every 10 years if you can tolerate it. So I put prostate cancer up there because this is one of the most common cancers in men. However, there's not great evidence to support screening for prostate cancer. We used to think that doing PSA testing was actually helping to reduce your risk, but recent evidence does not support that, and so most physicians won't even order PSAs anymore. Instead, they'll do a direct rectal exam where they'll physically feel for any abnormality in the prostate gland, and if it's positive, then we'll send them for an ultrasound biopsy. So I put that up there because prostate cancer, again, like I said, it's very common. It's only second to lung cancer as the cause of mortality. Most men with prostate cancer die from other causes. This is a very slow-growing indolent cancer that people can outlive unless it presents as aggressive in an early stage. Most people will outlive their prostate cancer. Unfortunately, in African American men, it is more aggressive and it does present earlier stages. So it's twice the age-adjusted incidence of whites. It's more likely to diagnose with advanced and more aggressive stage, and there's higher mortality in African Americans. So again, screening men over the age of 50, oftentimes we'll do a digital rectal exam, but then we might add PSA depending upon whether they have a family history of prostate cancer, or if they had a prior history of prostate cancer and we're following them longitudinally or serially, we'll want to check their PSA to look for recurrence. So that's the only other reason to really order the PSA. Again, it's not even a grade B recommendation by the USPSTF. It's grade C or lower, meaning that it's individualized to patient care, and there's not a lot of benefit in testing for PSA as a primary screening tool. Skin cancer, of course, you should be vigilant about anything on your skin that's abnormal or new growing. Basal and squamous cells are the most prevalent. Again, they're slow growing and they're rarely metastasized. They usually occur on the nose, face, and lips from sun exposures. The malignant melanomas are the serious ones. These are the ones that change their morphology or the color, or oftentimes they'll be associated with itching or bleeding, or it'll change in their nature. And these are the ones that you want to make sure that you get biopsied by your dermatologist. And oftentimes it's good to look at your skin in natural light once a year or once every 6 months to see if there's any new growth. Ovarian cancer is the fourth leading cause of cancer death in women. It's most common after the age of 60. Most women present with advanced diseases, meaning we do not have good screening tools for ovarian cancer, and we cannot pick it up early. It's usually stage D by the time we pick it up, and chemotherapy is a limited option at that time because the cancer is already metastasized, very high mortality, very low cure rates. But if we do annual physical exams and pelvics, the bimanual pelvic exam with the transvaginal ultrasound are the two key screening exams that you can employ to detect for ovarian cancer. Again, screening is not recommended. It's not a USPSTF A or B, and may not even be a C. So there isn't evidence to support it as a screening tool. Osteoporosis is the thinning of bones. As we get older, our bones become thinner. They're more prone to fracture and breaks, especially with falls. So this is something that's definitely preventable if we can screen for it. 70% of fractures occur in patients who are 45 years or older. The fractures involve the lower thoracic and lumbar vertebrae, so oftentimes it'll be the back. They'll be known as compression fractures. Usually after the fracture, patients will have a lot of debilitating pain, but then the pain over the period of 6 to 8 weeks will usually go away. After age 65, fractures of the hip and the arm produce greater morbidity and are associated with pain, disability, and decreased functional ability, and these patients are more prone to being admitted to nursing homes. Following a hip fracture, patients' expected survival decreases 15 to 20%. So again, these are very debilitating fractures that have increased morbidity associated with them. Again, females are more prone to osteoporosis than men. Not to say that men can't get it, but usually it's more common in females. Usually they're Caucasian, they're of slight build, and fair. They have low dietary intakes of calcium during their adolescence and early menopause. Again, women of Caucasian or Asian ancestry And usually a strong family history correlation. So if your mother or grandmother had osteoporosis, you're also most likely to get osteoporosis. Again, the peak bone mass is achieved in the third decade, after which bone mass or bone loss begins. It's accelerated by menopause because we lose that estrogen effect. Okay, we stop making estrogen from the ovaries after menopause, which does not then help support bone, and you get bone deterioration and loss. So again, the National Osteoporotic Foundation recommends comprehensive programs to prevent osteoporosis for women and men of all ages, adequate calcium and vitamin D, weight-bearing exercises. Again, these are your isometric exercises with weights. A healthy lifestyle with no smoking. So again, smoking, in addition to cancers and lung disease, causes osteoporosis, and alcohol as well. How do we check for osteoporosis? We normally do what's called a bone mineral density or a DEXA scan, which looks at the density of your bone. Again, we look at the BMD test, which is indicated when the risk factors are present. So not everybody will get a bone density test just because you're age 65. Again, family history or having some sort of risk factors for osteoporosis will get you a DEXA scan. Other conditions that there's actually no good screening for, and we don't recommend it, is screening for dementia. The MMSE test oftentimes has a very low sensitivity for early disease, so even if somebody does have dementia, we can't pick it up. It's not a very powerful tool. There's no good treatment options for dementia anyhow, so this is one of those chronic disease processes which unfortunately we don't have good treatment protocols. History of depression is probably the only thing that is a good screening tool to pick up patients who are at high risk for depression. Family history can be contributory in that sense, but patients who have losses, bereavements, loss of a job, financial problems, or illness normally have transient depression, and they're not at risk for lifelong depression. Other conditions that we look for as far as preventing are vision loss. So annually we do a visual acuity test, which is called a Snellen. We check for glaucoma and macular degeneration. Patients who have a bruit in their neck oftentimes will think that they have what's called carotid artery stenosis, but just having a bruit by itself is not enough to make that diagnosis. So you need to get an ultrasound. However, we don't screen people just because they have a bruit with an ultrasound. So carotid Dopplers are expensive. They're not a very good sensitive test for screening. And so just because somebody has a bruit in their neck, it does not mean that we're going to go ahead and do a screening test, a carotid artery ultrasound for them. There's no evidence for detecting for abdominal aortic aneurysms. There are newer indications that are coming out that if you have a history of smoking and you're a male and you're over the age of 65, there may be a one-time benefit of detecting for abdominal aortic aneurysms. But again, that's a USPSTF recommendation C, and there's not great evidence to support that. So what are our conclusions that we can draw from this? So there's not enough evidence about the effectiveness of health promotion and disease prevention in the elderly. Again, this is a patient population that we don't have enough evidence and data to support. Primary and secondary prevention may still play an important role in many cases. By the time you get to tertiary prevention, it's too late. Then we're just modifying the disease process and modifying the complications. And there's clear evidence for strategies. We've talked about immunizations, influenza, pneumonia, and tetanus, chemoprophylaxis with aspirin and statins I'll discuss next, making sure that we screen for hypertension and also cancer screening. So aging extremely variable. Every patient is different. Identify patients' goals and preferences when we have this clinic exam and we discuss prevention with them. We consider the patient's overall functional status and life expectancy. That determines whether we put patients on aspirins and statins and we screen them for heart disease and strokes and stuff like that. It's never too late to implement adequate preventive strategies in an elderly person at any age group, and obviously we need more data. So I'll get back to aspirin. As a chemoprophylaxis agent, it's for primary prevention of cardiovascular events, men ages 45 to 79, as I mentioned, and women ages 55 to 79, when the benefits outweigh the harms. And we talked about risk of bleeding and things of that nature. And again, there can be benefit both for cardiovascular and an independent benefit for colorectal CA with aspirin. So we talked about the USPSTF grade recommendations A, B, and C. And this cartoon says, I try to eat healthy. I never sprinkle salt on my ice cream. I only eat decaffeinated pizza, and my beer is 100% fat-free. So in his mind's eye, he's practicing prevention, but clearly it's not the case and it's not working. So what the USPSTF, or the United States Prevention Services Task Force, says that these are grade D recommendations and do not do them, okay? Don't look for in a service population, meaning don't try to find a subset of populations and do these types of screenings in them, because screening should be done at large, for an at-large population. Don't screen for abdominal aortic aneurysms in women, as we discussed. Only males age 65 or older with smoking history. Aspirin to prevent colorectal cancer, men under age 45, there's no benefit, so don't do it. And women under age 55, again, there's no benefit. Aspirin to prevent coronary heart disease or cardiovascular disease in men under the age 45, no benefit. Remember, the benefit starts at age 55 and over. Beta-carotene supplements in adults, largely there's no benefit to any supplements per the USDA, whether it be fish oil or vitamin D or ginkgo biloba or St. John's wort or whatever it is out there that this multi-trillion-dollar industry is trying to sell you. There's no benefit to any of that. And finally, I'll have an ounce of prevention than a pound of cure.